Hi, this is GNA, juvenile angiofibroma, and it is a benign tumor of nasopharynx, locally invasive vascular tumor commonly found in adolescent male between 8 to 14 years of age. And it is mainly composed of vascular endothelial tissue and lack of elastic fiber or smooth muscle in the tumor itself, which leading to excessive epistaxis. So this tumor classically present with nasal cavity or nasopharyngeal mass with nasal obstruction with unilateral epistaxis. Incidence is about 1 in 1.5 lakhs and it's common in UK and Asia. And first investigation of choice is contrast CT scan so that we can see the Hall Miller sign in the CT scan and mass in the nasal cavity or nasopharynx area, particularly in the pterygoid wedge area. You can see this is the Hallman Miller sign in the X-ray, plain X-ray. Same you can see in the Hallman Miller sign in the CT scan, and this is the investigation of choice in most of the juvenile angiofibroma cases. Diagnosis mainly done clinical, nasal endoscopic and radiological diagnosis. So biopsy, most of the cases biopsy is not required. If you doubt between the tumor and juvenile angiofibroma, malignancy or juvenile angiofibroma, you should do the diffusion weighted MRI. In diffusion weighted MRI, there is diffusion restriction seen in malignancy, while the GNA there is no diffusion restriction. So any doubt, you should do diffusion weighted MRI to rule out malignancy. Origin of angiofibroma, there are two theories about it. First is hematoma or vascular malformation theory. According to this is the most accepted theory. It is a vascular malformation in the area of spinopalatine foramen. Another theory is branchial arch artery theory, in which it is incomplete regress, and this regress near the pterygoid base, and which in the area of the spinopalatine maxillary artery, ultimately which connect to the C4 segment of intracranial artery. So this artery is incomplete regress, leading to vascular formation of this angiofibroma. Now, site of origin of angiofibroma, there are three sites: spinopalatine foramen, median canal, and pterygoid wedge. Spinopalatine foramen is the most common site. It arises from the upper margin of spinopalatine foramen, and it is a point of trifurcation. You can see pterygoid wedge, median and lateral pterygoid plates, and median canal is also site of origin of the angiofibroma, and pterygoid wedge is the most common site of recurrence. If any tumor is recurrence, if we didn't drill the area during primary surgery, then it is chances of recurrence in the pterygoid wedge area. It is a junction of the median and lateral pterygoid plates. You can see in this picture. If you see this trifurcation area of the spinopalatine fossa or foramen, there is palatine bone having orbital process, perpendicular plate of palatine bone, and sphenoidal process. There is three process of the palatine bone. And medially, you can see the horizontal plate of the boomer above near the sphenoid sinus. And you can see there is two pterygoid process, medial and lateral pterygoid process of sphenoid bone. So this is the area of the site of origin of angiofibroma. Microscopically, these tumors are grey to reddish in color, about 4 centimeter in average size, and it is polypoidal mass. On microscopy, there is fibrous stroma in the center and periphery filled with the vascularity, and there is lack of smooth muscles and lack of elastin fiber in the microscopy, and core of this tumor is fibrovascular in nature, made up of abundance bundle of collagen, and periphery is made by the blood vessels which are not having any smooth muscle and elastic fibers. As CCT is diagnosis of choice in angiofibroma, it is a Lyot's criteria. In Lyot's criteria, there is mass lesion in the nasal cavity, nasopharynx, or pterygopalatine fossa with you see erosion of posterior bony margin of spinopalatine foramen with the extension to the upper medial pterygoid plate is suggestive of the angiofibroma. As you can see in CT scan, there is bowing of anterior posterior maxillary sinus wall as well as widening of spinopalatine foramen and origin from the this pterygoid wedge and median canal area. You can see in this picture this mass is having expansible mass which going into the nasal cavity as well as in the infratemporal fossa. So on CT you can see erosion of the posterior bony margin of spinopalatine foramen, and you see this is Holman-Miller sign. What is Holman-Miller sign? If tumor is pushing or entry-bowing of the maxillary posterior maxillary sinus wall by the tumor, it is suggestive of angiofibroma. So another sign is Ram-Aran sign. What is Ram-Aran sign? It is a, if you see this coronal cut, there is widening of pterygoid wedge, which is mostly quadrangular shape in the angiofibroma. Normally, if you see, it is triangular in shape. Another sign is Ondosa sign. Ondosa sign, there is widening of the gap between the maxillary body and ramus of mandible when tumor is leading to in the infratemporal fossa. So any tumor in infratemporal fossa leading to widening of this area between maxillary body and ramus of mandible, and this sign is called Hondosa sign. As you can see in this picture, there is widening gap between body of maxilla and the ramus of mandible. The postoperative sign in CT scan of angiofibroma, it is called chopstick sign. If you see this picture on right side, there is chopstick sign. It is postoperative surveillance and there is residual or recurrent tumor shows floating median and lateral pterygoid plate where pterygoid base was drilled. Both pterygoid plate are look separated and look like chopstick, so it is called chopstick sign. And this is classical CT scan of angiofibroma, in which you can see there is contrast enhancing mass in the posterior nasal space and with occlusion of nasopharynx, and there is mild erosion of medial aspect of left medial pterygoid bone. If you see, there is erosion of medial pterygoid bone as well as this pterygoid wedge. And this is MRI, and MRI mainly done for intracranial, intraorbital or parapharyngeal involvement. You can see classical salt and pepper appearance on contrast, and there is vascular tumor always seen as salt and pepper appearance. On fat suppression MRI, there is immense potential in detecting the bone invasion by the tumor. Any iso or hyperintensity lesion in pterygoid wedge area indicate tumor invasion, and this type of patient require bone drilling in that particular area of enhancement or hyperintense areas. And MRI is also useful in monitoring of the disease. And this is the CT angiography of angiofibroma. It is CT is identify the feeding vessel to the tumor, and you can see this is the IMA, internal maxillary artery, is the most common feeder. Other feeder are ascending pharyngeal artery, contralateral external carotid artery branches, and sometimes there is internal carotid artery branches like median artery, meningohypophyseal artery, and ophthalmic artery sometimes also supply this angiofibroma, and they are also feeders of the angiofibroma, may lead to complicate the surgery. The knowledge about the feeding vessels and the site of entry into the tumor is absolutely critical to decide the surgery approach in the GNA. If you want to open surgery, so open surgery in require multiple feeders as well as involvement of intracranial extended tumor. So in endoscopy is contraindicated in multiple feeders as well as in the intracranial extension with ICA supply tumors. So you should not try tumor removal by endoscopically. You have to add on the open approaches sometime in these type of the tumor. And this is the DSA of angiofibroma patient. DSA is used preoperatively to identify the feeder vessels and embolization. The selective vessel angiography in DSA allows to determine the exact branches and branch of the which supplying the angiofibroma, and it also help in selective embolization of primary vessel. If you see the UPMC classification, that is Syndrome's staging system of operative embolization and preoperative embolization staging of angiofibroma. Grade 1 is nasal cavity, median pterygoid fossa involved. Grade 2 is paranasal sinus involvement with lateral pterygoid plate extension, and there is no residual vascularity post embolization. Grade 3 is skull base erosion as well as orbital infratemporal fossa involvement with no residual vascularity seen in post embolization. And grade 4 is there is residue with skull base extension, and grade 5 is intracranial extension with residual vascularity seen in mainly coming from the internal carotid artery. So this is staging only useful in the embolization stage, when you did the embolization of the patient preoperatively, so that your tumor can be resected without much bleeding. Now talk about diagnosis. The diagnosis of angiofibroma mainly clinical plus radiological diagnosis with classical finding the CT contrast CT scan, and that is first investigation of choice. But sometimes you may confuse, or you can say differential diagnosis of angiofibroma like enteroconal polyp, large adenoid, chordoma, tumor in postnasal space, teratoids, dermoid, teratoma, neuroectodermal tumors, rhabdomyosarcoma, hemangioma, craniopharyngioma are differential diagnosis of angiofibroma. Staging of angiofibroma. Commonly, we are using the angiofish classification. According to the stage 1, tumor limited to nasopharynx and nasal cavity, bone destruction negligible or limited to the spinopalatine foramen. Stage 2, tumor invading pterygopalatine fossa, maxillary sinus, ethmoid sinus, sphenoid sinus with bone destruction. Stage 3A is tumor invading infratemporal fossa, orbit or without intracranial involvement. Stage 3B, tumor invading ITF, orbit, intracranial extradural extension. Stage 4A, intracranial intradural tumor without infiltration of cavernous sinus, pituitary fossa or optic nerve. And stage 4B is the intracranial intradural tumor, infiltration of cavernous sinus, pituitary fossa and optic chiasm. Simply you can say bony cavity stage 1, nasal cavity stage 1, stage 2 is the sinus and spinopalatine fossa. Stage 3A you can say without intracranial ITF. Stage 3B ITF with extradural extension. Stage 4 intracranial intradural, but it is not involving the cavernous sinus. In stage 4B it's involving cavernous sinus, pituitary fossa and optic nerve. So this is simple classification. You can say you can classify this as simple and complicated. If it is envisaging the structure which are difficult to operate, then this is complicated. Simple, whenever possible you can operate by the endoscope, that is called simple staging. The goal of angiofibroma surgery is complete resection of the tumor, minimum morbidity, and avoid recurrences radiation therapy so that we can treat. So first treatment is surgical only, and according to that we have to complete resection of the tumor is required, and drilling of pterygoid veins. The surgery of angiofibroma, there are two approaches mainly: open approach and endoscopic approach. Sometimes we combine both approaches in advanced angiofibroma. Mainly open approach needed in broad skull base involvement, extensive blood supply. There are multiple feeders from behind the tumor. Then we require open approach. Encasement of the intracranial artery, in that we require endoscopic as well as open approach or intracranial approach. And brain involvement, then we required intracranial as well as open approach. So these are four indication of open approaches. And open approaches are transpalatal approach, transfacial approach, infratemporal fossa approach, transcranial approach, and midfacial degloving approach. And endoscopically you can do medial maxillectomy approach or endoscopic pterygoid approach. So these are the approaches to do the surgery. Sometimes we require combination of multiple approaches.